We have next is going to be KRAS, a patient's journey. A little bit less like super brain intense, but definitely what it is that we kind of like all need to know and follow. So Dr. Christopher Pallas is a clinical and research focus in thoracic and head and neck malignancies. He practices at the Levine Cancer Institute campus here in Charlotte, North Carolina, beautiful Queen City. And his clinical research interests focus on targeted treatments, immunotherapy for lung cancer, drug development, and bridging the gap. We call those the KRAS holes. Bridging the gap between the lab and the bedside through translational research and biomarkers for lung cancer. So come on up and let's hear what you have to say. Let's get this party started. Thank you, guys.
I don't. I need to get a pair, so we'll do that. Well, I want to thank everyone again for letting me come and talk with you all. So very excited to. Thank you.
Sorry,
Appreciate
Terry,
it.
I had to do that.
No, thank you. I always felt I was the short one. I grew up and my brother's taller, my dad's taller. So then, you kind of go out in your world and you're like, okay, I guess I'm a little bit taller than I thought. So, but a little bit about me. So I'm a medical oncologist. I treat patients with lung cancer and head and neck cancer. I do that here in Charlotte, North Carolina. So again, very happy to speak with you all. And thank you, Terry, for the kind introduction. So what I wanted to do is focus a little bit more on the highlight of the patient and kind of one of my patient's journey with lung cancer. And I think this is a conference or a summit of hope. And kind of just talk a little bit about what could be coming in the future. And hopefully we can get the slides to pop up on. Oh, perfect. Let me check. Got it. Okay, perfect. So let's just kind of start with our patient. So he's coming to see us, 59-year-old gentleman, had just moved to Charlotte, North Carolina from the Northeast, had come in with a diagnosis of locally advanced non-small cell lung cancer. So certainly we want to get to know a little bit more about our patient. So he was initially diagnosed with a large left lower lobe adenocarcinoma of the lung, measuring over 7 centimeters, had some lymph node involvement in his mediastinal lymph node, which is that middle of the chest, kind of the deep lymph node, meaning a little bit more of an advanced lung cancer. He received chemotherapy and radiation in the hope to cure his cancer, and afterward went on immunotherapy with a drug called durvalumab, again trying to increase that chance for cure, and then moved to see us and transfer his care and continue on his immunotherapy. So before we jump a little bit more, let's just kind of go into the basics. And a lot of what I'll be doing is giving a little bit more of a bird's eye view and hopefully giving some highlights and some pertinent points. So lung cancer, I think a lot of us know, but just to kind of reiterate, we're looking at those cells in the lining of the airway that change or mutate. They're no longer behaving normally. So they kind of take away the rules of normal growth. And so why is it important? Well, lung cancer is the leading cause of cancer death worldwide. And how do we stage it? Staging is where we take a look at where has that tumor started, has it gone anywhere, and it gives us an idea of the risk of that tumor. So we talked already earlier about kind of differences between even stage 1 and stage 3. So if we focus on our patient, he had stage 3 lung cancer. Again, that's a large tumor, but also was spread to those deeper lymph nodes in the chest. I kind of view it as that tumor took that subway track through the lymph node system, and it's kind of getting ready to jump off the subway. And unfortunately, we hope prevent, but at risk to spread to other parts of the body. And then stage 4 being something that's spread more distant, whether that's in the fluid in the lung or whether that's somewhere further out like the liver or the brain. We have different types of lung cancer. How do we traditionally classify that? Well, that was really kind of from a very basic level, non-small cell and small cell, but we'll talk about how we're kind of changing our viewpoint on that. How do we treat lung cancer and how we treat most cancers in general? Traditionally, we thought about local therapies. Surgery, can you go in and cut it out? Or radiation therapy, is there something where you can basically zap the tumor? And then what I do, which is chemotherapy or more whole body therapy. You might hear us use the term systemic therapy, that again meaning more whole body, not directed to one specific site. But as we moved more, how can we personalize or how can we individualize our treatments? And that's what I think the real exciting part, especially in what I do, is that more targeted therapy, which we've already had some really fantastic discussions and presentations on, and certainly people much more eloquent than myself. And immunotherapy, how do we harness our own body to target and attack the cancer? So just to remind ourselves with stage 3 lung cancer, well, what's kind of the current standard of care? And for years and years, it had been that combination. These are patients who are not resectable, right? So we can't get surgery. So we're looking at what is our next step to how we can try to cure this. And for years, it had been combination of radiation therapy, adding chemotherapy to that, both to hopefully enhance the effect of radiation, make it more effective. Also, if we're giving higher dose chemotherapy, hopefully killing off any tumor cells that may have leaked out. But we found that that wasn't good enough. So what else can we do to add? So that was where we looked at immunotherapy with that checkpoint inhibition, specifically the drug called durvalumab. Can we use that after chemotherapy and radiation to hopefully harness, again, our immune system? Can we basically give it the guard dogs or our surveillance system as a way to try to knock out that cancer and keep it away? And that's what, when we studied in the Pacific trial, which was kind of the landmark or groundbreaking study using immunotherapy in stage 3 lung cancer, after, again, having received chemotherapy and radiation. And what we found, and if we go back to kind of our math and science class, when we're looking at these graphs, we're really looking, the key thing is, can we get separation? If we're looking on the top, which I believe is blue, that's those patients who received immunotherapy after having chemotherapy and radiation, and that red is those who did not. So what we're looking for is on the left, how many patients did it keep the cancer away for longer? That's what we call progression-free survival. And on the right, how long did patients live for? And we kind of term that overall survival. And what we're looking is we want to improve both, right? We want to improve keeping it away for longer and hopefully curing the cancer, trying to ultimately help you live longer too. And so what we're seeing is that separation. So we see a benefit with the addition of immunotherapy. And that led to the FDA approval to adding that as a standard of care. Unfortunately, that was back in 2018. We're now 6 years past that, so I think certainly a lot of room for improvement. And so we just wanted to look, we talked a little bit, I think there was a question earlier about clinical trials. They're very black and white. We're really trying to, I think the question is, well, how does that kind of work just in the real world? So we just did a study here at Levine, just looking back in time at how did our patients do receiving this standard of care. And again, we're looking for that separation. I think what we've found is, and this is consistent with a lot of other studies that come out, is that those who respond to the treatment do better. So there's a group of our patients, as you'll see on the bottom, that receive less doses overall, unfortunately, have a more resistant tumor. And it just really highlights that, yes, immune checkpoint inhibition, yes, it is really groundbreaking. It's been great for our patients, but we have a lot of room for improvement. We have some patients that respond, some patients that partially respond that we see in the middle, and then those who really are primarily resistant. And that really raises the question of how can we delve further into who will respond to therapy? How can we predict before starting, okay, do we expect this therapy to work? And if we're concerned that it's not, how can we try to overcome that resistance? So let's bring it back to our patient. So he has come to us after moving. He's now on immunotherapy with durvalumab. But he's telling us that he's having more headaches, just kind of increasing in frequency, just a little unusual for him, hasn't had that issue before. And he's noticing a little bit more shoulder pain. He works out a lot. He's like, maybe I just kind of strained my shoulder, but it is something new. And so we got scans, and we take a look, and unfortunately, we find that the cancer, despite our best efforts, has gone now to the brain. It's grown in the lung and even gone to the other side, and we see it in the bone as well. And so, next steps, we want to get tissue. We want to make sure that we confirm what's going on, that we're not missing something, unusual or different. And unfortunately, a biopsy confirmed recurrent non-small cell lung cancer. And so again, this brings up that question of why do some of our patients respond really well to certain therapies, and why do some patients not respond as well? And that's, I think, a big area of what we're trying to look into. I think in previous investigations, we're looking at not just single mutations. We talked a little bit, I think, earlier about KRAS, but what about the combination with STK11 or KEAP1? I think we're looking at those co-mutations. How do they interact together to adjust our immune environment and perhaps limit immunotherapy? And so again, that moves into this personalization of lung cancer. We mentioned before that we initially just looked at the cancer. How did it look under the microscope? Is it non-small cell? Is it small cell? Or we call histology. Is it that adenocarcinoma or squamous cell carcinomas, which are that form of non-small cell? But I think we learned that that's really not enough to predict how we're going to do on treatment. And so now we're trying to personalize more. How can we look at a tumor's makeup? What about the molecular profile, the immune signature? And that's a lot of what we're looking into. How can we guide and direct that care? And in the metastatic setting, if any of you have read up, which I'm sure most of you have in this case, is we use PD-L1 as the current marker in the metastatic settings. Cancer that's spread further out as a marker of how well is immunotherapy working. And what that is the pathologist is looking under the microscope at the tumor cells, and he's placing a stain for that PD-L1 marker, and he's looking at how many of those tumor cells express that protein. So how many of them light up once you put that stain on. And it's not perfect, but it's the closest we have at the moment to predict how well we think immunotherapy will work. So anything that where they look under the microscope and 50% or more of the cells light up, then we think that we have a better chance to respond. And if we're treating someone who has cancer that's spread, the standard can be immunotherapy alone, so say pembrolizumab alone. Certainly you have the option at chemo if you want, but you don't have to. We found that immunotherapy itself still can be efficacious. That 1 to 49% is a bit more of a gray area, and then that 0% we really get worried about the ability of immunotherapy to work on its own. And so I think the question that it asks is, we just mentioned that's in the metastatic setting, but in the stage 3, we currently have no biomarkers. We don't have any real true markers that change what the standard of care is, right? It's mostly all comers who come in. We're treating with chemotherapy and radiation together, and then we're giving durvalumab. But I think as we're learning that we can use these markers as ways to predict resistance, open up clinical trial options. Unfortunately, stage 3 lung cancer recurs more often than not and more than we want. And so we need to find better ways. And I think understanding a molecular profile, should we be incorporating targeted therapy? And that's what a lot of trials we have up and coming that are currently ongoing is really important. So I certainly agree the earlier to do biomarker testing, both a comprehensive panel I think is certainly important. And so we just kind of looked at, well, let's just go back in time with our patients, and our kind of hypothesis again that we can predict perhaps resistance to therapy. So, a lot of times we start by doing what we call retrospective. Let's just go back in time, look at our patients that have had this type of cancer, that have had the tissue collected. Can we find between our patients who respond and don't these resistance markers or response markers? And so again, we're kind of identifying the patients, we're then screening, and we go back and we're analyzing that. So we've certainly done that here. We're hopefully, I can't speak on some of the results we have, but we certainly want to open that up and look a little bit further understanding these mechanisms. What about in the metastatic setting? We do have a trial here, and I think most centers do, where we're looking at blood-based markers. Can we use an immune signature and a genomic makeup in our patients to predict response? And what about the metastatic setting? We talk a lot about resistance, but what about our patients who respond to therapy, that are actually doing quite well? Can we look at how those patients might respond and how is it different from someone who doesn't? And can we use those differences to get a better understanding of that makeup? And so that's something that we do have currently enrolling here, where we're looking at not just immune signature. We talked a little bit about the circulating tumor DNA. That's a big thing in colon cancer. Lung cancer, we're still a little bit behind. It's certainly something that's going on in a lot of clinical trials we have, but it is not considered standard of care yet. So if we kind of bring ourselves back to the patient, so unfortunately he's come to us, has now been found to have recurrent and metastatic non-small cell lung cancer. And so we kind of, just for those who are a little bit more visual learners here, again, we've now diagnosed by biopsy, which again, I certainly agree. I think getting tissue markers is always the gold standard. We always could say tissue is the issue as you want to try to get. Certainly if you can find it in the blood, I trust it if you have that mutation there, but I've had multiple times where a patient who's had, say, an EGFR mutation or even a KRAS G12C, that we will do a blood test. Again, some tumors are not shedding. We get a tissue biopsy and we find that mutation. So I think it's not enough to just stop at a liquid biopsy, but it certainly does offer a maybe more expedited approach, starting with that liquid biopsy. Just a little comment there. So what's next? Well, I think everyone knows. If you haven't already, it's comprehensive biomarker testing. Certainly at the time of recurrence, I would always suggest repeating that testing so we can better understand how that tumor has changed. Not just for if we're looking at standard of care, certainly clinical trials. And how do we kind of look at that? I break it down into, well, how can we look at targeted therapy? We're looking for driver mutations. Is there an EGFR mutation that opens up, osimertinib being the current standard? But we're looking for others, ALK, KRAS, ROS1, looking both for standard of care, for trials, and then what about immunotherapy biomarkers? So we're really trying to look at both, and that's that comprehensive panel. And just a quick note, these are just our pathways. It's the guidelines that we've set up at Levine that we have throughout our system. The little test tubes are trials, so the whole goal is we're trying to integrate, so whatever Levine Center you go to, throughout North Carolina. We've now expanded with Wake Forest and other states. You can always have those trials available, see what's open here. So it allows every provider to have that access. But I just want to make a quick note. We've talked a lot about comprehensive biomarker testing, and there's kind of 3 scenarios, and I kind of view that almost like a timeline. You know, if we rewound 10, 15 years ago, pretty much scenario 1, it was most patients will come in, metastatic lung cancer, and we're treating with chemotherapy. As we found more mutations, we looked and found EGFR, ALK and ROS. It became, well, let's test for specific mutations that maybe open up pill options, more targeted options. But I think we found, again, that's not enough. We wanted to get a whole view panel of our patient's profile. And that's where we come into that kind of multi-genomic testing, where we're looking, again, at for driver mutations, immune signature, and even more. And so what about our patients? What did his come up? Well, certainly we had a lot more there, but what was kind of pertinent for what we're discussing was found to have a KRAS G12C and an STK11 mutation. And so we'll talk a little bit about that combination just very briefly, but certainly I think I'm repeating what everyone else has already kind of mentioned, but historically we looked at KRAS as being an undruggable target. You know, for years we would try therapies, and unfortunately they would not work how we would like. But I think we're in a really exciting time where we're seeing a lot more progress and help for our patients. And so I think that led to a new hope. And specifically from lung cancer, we're looking at G12C, but certainly many more kind of areas that we're trying to focus on and help. So how did we get here? I think I'm repeating some slides as well, so I won't. Again, I know I'm the person in between lunch, so we'll make sure we don't want anyone getting hangry too much. So. But we came through the code break trial and the crystal one, which was looking at sotorasib and adagrasib as well. And these were just early phase trials that showed that, hey, it works. Certainly we want to take a look in a larger trial to see how does it compare to our standard of care that we have at the moment. But we know that we have efficacy, and that led to the FDA approval. And so again, these are, what is our current standard of care? How do we at least set it up here? And this does fit with a lot of our national guidelines that you have. So you might have heard NCCN, which they do have a lot of good patient resources as well to look. But in our patients who have received first-line therapy, so have already received chemotherapy and immunotherapy, because this is how it was studied, the current standard that we have set, if we have a KRAS G12C mutation, is to look at sotorasib, adagrasib. I certainly would still consider clinical trials as well on top of that, but if that's not available, we do have these pill options for targeted therapy. And so just a couple considerations. A lot of this has been brought up already, but just things to think about. You know, certainly with these drugs, they're not perfect. I think we have a lot of room for improvement. Part of that's looking at larger trials. How well does it work in a larger population? That's what we talk about phase 3. What about resistance mechanisms? And how can we personalize it? You know, a little bit about the CNS outcomes, as we've discussed a little bit already. How do we combine this to make it better? Or do we have novel agents, newer agents? And what about the safety? So I just want to start with just kind of what's important for you as a patient as you're coming in. Well, certainly we notice some class effects between the two pills, that they can cause liver toxicity and inflammation in the lung. So just really important to kind of keep that in mind for things you watch out at home if you're starting therapy is, one, you need to get your liver function test checked about every 3 weeks just to ensure that you're not running into any possible severe side effects with the medication. And just because you may have a little bump in that doesn't mean you need to stop or even adjust, but it's just being safe for you. And also watching for inflammation in the lung. That's what we term pneumonitis, so watching for shortness of breath, cough, or even fever, usually a combination of that. Some interactions, if you're on sotorasib, just important to remember that there is interaction with what we call our kind of reflux medications, so like Pepcid, Protonix as well, but looking at that combination can run into interactions that increase possible side effects. And with adagrasib, it can interact with a heart interval called QTC, so watching medications that might prolong that. There's a lot of good sites online. You can actually type in medications and check, but certainly, hopefully, your oncologist will be looking at that as well. And then adagrasib has a specific, what we call GI side effect that happens most often in the initial beginning of treatment in that first 6 weeks with some nausea, diarrhea, and vomiting. What I have found is that it is something that's very manageable in the overall grand scheme. Certainly, unfortunately, not fun in the beginning, but working with nausea medications, anti-diarrhea medications is certainly something that I think is very easily able to overcome and stay on the medication. But it is something to keep in mind that we do have to sometimes hold the drug, sometimes lower the dose, but overall still something that I think is able to remain on. What about some resistant mechanisms? So we've already talked a lot about that. I just want to focus a little bit on the KRAS STK11 for our patient, right? How could that have ultimately affected his treatment? And again, going back to in stage 3, we don't have any standard of care biomarkers to guide what we're doing. And so we are seeing these co-mutations, specifically KRAS STK11, KEAP1, or just things that we see consistently in the literature as possibly providing more resistance to immunotherapy. It just hasn't been studied on a larger grand scale where we say randomized, we put people half a population that have this mutation that are receiving immunotherapy and not. So we can't say 100%, which is why it hasn't changed a standard guideline, but it does make us worried. And I think as discussed before, it's something I talk with my patients about to let them know, hey, I am worried about how we're going to respond. What about CNS activity? Because again, we mentioned our patient did have the cancer spread to the brain. So just a little bit point with adagrasib was found to, again, be studied in patients who have untreated CNS metastases. They took patients, gave them the pill, and assessed how it worked. So the standard of care before currently had been if you have multiple, and so in his case, a little bit more history, extensive brain metastases, so not enough that could be targeted with a single radiation dose. It's multiple, usually portends needing what we call whole brain radiation therapy. And certainly that has its own possible set of side effects. So if we have something that can penetrate that blood-brain barrier, a lot of times I think that's a preference for a lot of us as oncologists. And so what we did find is adagrasib did show what we call intracranial activity, where they found that it had a control rate up to 90%, and found that it actually would shrink about 42% of the time, so almost half. And that did lead to the NCCN guideline change, and a patient that is not overtly symptomatic, that we need to really be worried about needing a quick response, that it is appropriate and okay to use the pill first and assess for response. So it gives us an option that's not radiation that has its own set of side effects. And then combination therapies, again, not to kind of belabor what has been already discussed. This is a trial we've had at Levine, although I think a lot of the arms are currently closed at the moment, but it's just looking at combination therapies. There's studies with sotorasib, there's studies with adagrasib. How do we combine to try to make it better? And not just combining it in the, what we say, second or third line after you've received the standard of care, but what about first line? Can we add immunotherapy? Do we need to be adding other KRAS inhibitors? How can we make it better? Because again, it's not perfect. And so I think it's just some highlights, kind of more bird's eye view as we take a step back. Again, very important, can't emphasize enough. Please remember molecular testing. I think there's a lot of hope, there's a lot of innovation. What was once an undruggable target, we're now developing more treatments, and we have 2 that have now been approved with sotorasib and adagrasib. Resistance to therapy is still an issue, but I think that's why we need to be studying this, and we need to better understand how it's working. And so I think there's a lot of hope for the future in that. And so a follow-up visit on our patient, we started adagrasib, had a great response in the brain and the body, and he remains on it a year later. Certainly doing much better than what the average, but I think, again, it shows a certain hope that we can come up with more and more treatment options for our patients. But what happens once the cancer becomes resistant to therapy? So again, more bird's eye view. Again, really would stress broad molecular profiling, a repeat biopsy if you can, whether that's starting with a blood-based test and then getting a tissue marker. It can always be tough if it recurs in the brain and not anywhere else. That becomes a really hard place to get a biopsy. Clinical trials, I think from lung cancer, really in any stage is always appropriate to really try to push and consider. And if neither being available or no marker, chemotherapy has been the standard of care. Just a couple highlights, clinical trials. I think the Pragmatica is one where not so much a targeted trial. This is just a phase 3 study, so one of the kind of larger trials, but I think is pertinent, as we mentioned, a lot of the red tape that comes into trials is this was a joint effort with the FDA to try to limit a lot of that, to hopefully enroll more disparate populations, to hopefully enroll more patients. It really lessened the amount of inclusion-exclusion. So it's a second-line study after our patients have had progression on first-line immunotherapy and chemotherapy. And it's looking at adding ramucirumab to pembrolizumab, ramucirumab being what we call VEGF inhibitor. It kind of tries to inhibit the tumor's ability to grow blood vessels, but really limited a lot of the requirements trials have. Most trials require specific amounts of blood testing, specific locations where it has to be done. So we really tried to lessen that. I think the protocols, usually you look at 100-page documents. They try to cut this down to just 30 pages. Certainly other trials that we have available, but I would certainly just encourage, I think you're your best advocate. Clinicaltrials.gov is an excellent site just to start, but I would also talk with your oncologist or your provider about what might be available, whether at that institution or anywhere else, or say, hey, I found this trial. Do you think this would be appropriate? Because it can get confusing with all the possible trials, whether a trial's enrolling or not. Even we get confused, in certain arms, it's something still enrolling, so we always have to check ourselves. And so additional take-home messages, just extra stuff I just like to emphasize, but we haven't really talked. Lung cancer screening, I think, is extremely important, especially as, we haven't focused too much here, but our earlier stage lung cancer, we're finding more and more possible treatment options for our patients, whether that's with targeted therapy. We've had that approval for osimertinib after having resected lung cancer. But also using immunotherapy and doing that neoadjuvantly, so using that before you undergo a surgery, and then using it afterwards as well, as was shown with pembrolizumab to find benefit. A multidisciplinary approach, so not just kind of getting one set of eyes. Certainly we have our own specific multidisciplinary tumor board where we're able to discuss our patients. We're able to get input from not just the entire team of oncologists, but also radiation oncologists, surgeons. So certainly important to make sure you have everyone kind of on your side. Important to order biomarker testing. I think that's extremely, can't emphasize that enough. That's how we're really going to hopefully better understand your cancer. And then consider clinical trials when appropriate. So, thank you.
Would you like me to make this higher so I can reach it?
Here.
Okay. All right.
Take that.
Questions? I already see the hands are jumping up high here. No. Now it's on. Okay.
Quick question about dates and timing. Was the Pacific trial, was that 2017?
Yes. Well, not exactly when it started, but when we really got the data. And then 2018, I think, was the FDA approval.
And you mentioned also on the chart 2007, 2009. 2007 was when biomarkers were first identified, or?
Oh, I would honestly have to go back and see. I think it's been an
Okay.
evolving field, so I can't, honestly, off the top of my head, can't remember exactly the dates.
So those two dates you don't remember exactly, though?
Mm-hmm.
Okay, thank you.
Questions?
Thank you for your presentation. I am a caregiver to my mom who has lung cancer, and hers was caught at stage 4 with a fall. She had smoked about 8 years, but it was literally 45 years before. So I'm interested in screening. I know you mentioned that at the end. I have 3 family members who have had it, but it seems like the criteria are so strict. Are you seeing any progress in getting more early detection and screening?
You're right. That's the big area of both interest, but then concern too, is that we are trying to, they recently lowered the age limit for what was needed for lung cancer screening, but that still required a certain amount of smoking history. So we don't have any screening for our patients that have never smoked. There are certain blood-based testing that's coming out that, I don't know if it's not quite anything standard. You might have heard about GRAIL or Gallery, but using kind of blood-based testing to screen, again, not standard, but it's areas that I think we need to improve on in the future.
Can I just add something?
Scott?
I think so, yeah. Can I just add, so at NYU, we actually have a screening program for patients who have never smoked or who have very minimal smoking. And the reason for that is that there are some mutations that are not necessarily associated with smoking, and oftentimes folks are not, they're not screened at all. And so we have an entire program for patients who are high risk.
What about their family members?
And their family members.
This is something that was intriguing when you mentioned the HLA, which I had not heard about, and I feel like I'm pretty steeped in this, and so thank you for that. Is there an opportunity with the HLA to somehow or another connect that? You mentioned the mom and the dad. Is there any possibility that some of that leads to this concept that maybe, as much as we always have said, that there's it's not hereditary, but maybe it could be?
Yeah. So, sorry, I don't mean to poach too much on this. It just happens to be an interesting topic to me. But yeah, so in patients who have never smoked, we do believe that they have some genetic reason that puts them at increased risk of developing a cancer, maybe in addition to environmental factors. And so yes, we are doing those testings. So patients who have cancer, their first degree relatives are being tested for these kind of like rare odd mutations to see if that's actually what's increasing the risk.
There's other stuff that's happening around that too. Questions on this side of the room? Good thing you waited.
So are you, I'm curious about the neoadjuvant, both chemo and immuno prior to surgery, and if you're seeing that, I know that there was a time it was always just after, and I'm hearing more and more about before and seeing some pretty impressive results as it results to that. So are you guys seeing more of that, and how's that affecting treatment?
Yeah, no, I think that's the really exciting part. So right now it is approved technically for tumors that when diagnosed are larger than 4 centimeters or have lymph node involvement. That's what was studied. There's different ways you can do that. So the standard that had been was surgical resection. So a surgeon would go in, cut out the tumor, not just the tumor, most often is a lobectomy, but there's certain specifics that go into it, and would remove the lymph nodes. And based on what we found afterwards, we would consider what we call adjuvant. So you have your surgery, which is considered definitive therapy, afterwards being adjuvant therapy. And based on the risk after they would cut out the tumor, it would look under the microscope and say we would get worried about certain size, lymph node involvement, or other markers as a way to add treatment, usually chemotherapy, and then more recently immunotherapy, or even targeted markers. Now, osimertinib has been approved after a surgery in someone who has a EGFR mutation, specifically the exon 19 and L858R mutations. But we certainly have trials that are looking at, ALK is certainly something that's very promising as well. So again, brings in the biomarker testing. What we've looked at more recently is especially, when we were discussing the vaccine trials, is there's a lot more, we call antigens, in that when the tumor is still in place. And it's a little scary concept to think, I have a tumor, why are you not cutting it out right away? But we're finding that how our immune system interacts with the tumor certainly might have that benefit of actually treating earlier before it's been taken out. So can we develop that immune memory and response, and can we do that first? And so the approvals currently are, we have a neoadjuvant approach that was through looking with nivolumab in combination with chemotherapy, and then after surgery did have the option for some more chemo and radiation, but did not continue immunotherapy. Pembrolizumab was studied to look at it neoadjuvantly, giving chemotherapy and immunotherapy, and then after the surgery, continuing on that pembrolizumab. So we call that more of a perioperative approach. So we have multiple different ways, but I think it is something that we're seeing more and more. Part of it that I have seen a little bit more in the community is how comfortable a surgeon is with that approach. I think it's, again, that concept of you worry about if I get a side effect before surgery, is that going to limit my ability to get that surgery? I think we try to balance that with what the pros are with it, and that we can hopefully really develop that more immune response, have a much longer lasting response. And that's why a lot of the trials looked at more advanced tumors first, larger tumors, more than 4 centimeters, or lymph node involvement. So something where, to us, there's always an unacceptable, but an even more so rate of the cancer coming back. So we want to kind of balance what the pros and cons are of doing therapy first that could have its own possible set of side effects. So it is something that we see a lot, and that's where the multidisciplinary approach comes in, because I think it's having an oncologist perspective, the surgeon perspective, so we can say, okay, is this approaching a patient for that type of approach? And we have multiple minds thinking about it. It's not just one person's kind of knowledge, it's the whole group's knowledge.
In my experience, sometimes, in regards to biomarker testing, and especially with KRAS, whereas before G12C inhibitors came to be, doctors are likely not to do any biomarker testing upon progression because practically, there's very unlikely to find anything that's actionable. And sometimes I see a lot of patients and caregivers feel like it develops an adversarial relationship between them and the physician. And so what's a good way to bridge that gap so that that doesn't happen and it feels like they're not being underserved? especially for someone who has like a G12V, they progress, and whether or not you're going to order a test like that.
Yeah. No, I think that's an excellent question, and that's the part where biomarker testing, which again, kind of the broad term for a lot of times we interchange that with next generation sequencing or whether kind of in-house models, has been an evolving field, and that's been, I think, a comfort level from every different physician has kind of a comfort and a standard practice. But I think certainly being your own advocate, saying, hey, you know, as it's progressed, is there any role to doing additional biomarker testing or biopsy so we can consider, you know, clinical trials? And I think broaching it even yourself. So if you're not kind of hearing it from your provider, broaching it as well as, hey, what about this as an option? And that should really kind of ring bells. I think we're, you know, every kind of guideline that we have here at Levine, or you look on NCCN guidelines, which is kind of the publicly available national guidelines, do suggest biomarker testing, certainly if feasible. You know, I think that's always the question is, can you actually get the tissue? But even liquid-based or blood-based biomarker testing as well, if you don't have somewhere that you can biopsy.
It can be very frustrating trying to needing to go in and get another biopsy. Any questions? Okay. Yeah, okay. No. Careful.
I know. I have a question. I had my biomarker testing in a kind of a roundabout way, and I never had my results explained to me. So I know that I'm KRAS G12C, and I hear a lot of people talk about PDL1. And PDL1 isn't listed on my biomarker testing, but the TMB is. Are they kind of like I don't know, I don't understand the relationship.
Yeah, and that's part of it, how the biomarker testing has evolved. Every institution has a different standard in how you do it. Oftentimes it's different order sets. So part of it is what has been studied, and then if you're following, and some sites will only do what they consider is been approved or standard of care. So a lot of our trials where you look at, we mentioned the neoadjuvant therapy, so with pembrolizumab, did not actually require biomarker testing. So there were patients that had EGFR mutations that were still studied on that trial. The Checkmate trial with nivolumab actually excluded patients with EGFR because there is evidence that it does not respond as well. So it's an area that I think we keep growing in more institutions, especially large institutions here, where we push more for a comprehensive approach. And so you're right. So PD-L1 is actually more of what we call an immunohistochemical stain. It's how that pathologist stains the tumor tissue itself. And so that they have to look under the microscope, take a look, rather than more of a sequencing or mutational approach. So for us, just from a practical standpoint, it's oftentimes, if it's not standard at your institution, you have to send a separate order set for it. So it has to be kind of something that you send separate already. A lot of companies that do testing, so thinking of like KRAS or Tempus or those types of companies, you do have to, again, kind of make a note to check that testing as separate. Colon cancer, you look at kind of your mismatch repair, and that, again, those are just for practical purposes, again, kind of testing. And hopefully that's something being looked at, but it is something that has to be thought of. It's not inherently or always reflexively done.
Mine was done by Foundation Medicine, and Dr. Levy at Johns Hopkins sent it off. My original cancer care team refused biomarker testing for me, and so I went beyond them. So I just don't know what TMB means to me.
Yeah, and that's always the truth. So TMB is tumor mutation burden. It's something where we're looking at where there's a kind of pan approval in our patients that have had resistance to other treatments, so don't have technically standard options left. If you hit a certain that kind of high profile or high tumor mutation burden, we expect that there might be more of a response to immunotherapy. Technically, that's the only time where we can use it from a guideline perspective in care. And so sometimes that's where it's not always been as reported, like PD-L1, right? So for lung cancer, we do not use PD-L1 to guide stage 3 lung cancer. Durvalumab is still technically standard. We don't have PD-L1 as a guide for neoadjuvant therapy or that perioperative therapy. So it can be from a financial toxicity too. We think for our patients in terms of now insurances are covering most of this, so fortunately we don't have to worry about it as much. But if you rewind years ago, most insurances would not cover a lot of this testing. So part of it is also bearing in mind what is affordable as well. And so we have to think about what's going to truly change the care, or if, heaven forbid, the cancer comes back, do we then send that testing at that time when it will be covered, but won't necessarily change how your care is managed overall, if that makes sense.
I guess I hear everyone talking about PD-L1 and PD-L1 determining whether or not they'll be responsive to immunotherapy.
Yeah, well,
And so I don't know why I don't have a PD-L1 score and I only have a TMB score. I don't understand that.
so again, it's different sets of testing. So if you're sending through Foundation, which is, what?
I was going to say, they did hers after the fact. It wasn't part of the initial diagnosis and,
Yeah.
and stuff. Isn't PDL1 like the IHC is like a quick stain and
Yeah.
quick decision, as compared to where they take the tumor, a piece of the tissue, send it off to the pathology people, and NGS magic happens, and you get back a score of 400 whatever. Right,
Yeah.
so it's kind of like a different thing. So
So they're two
that might be
separate
part of it.
tests, I
Yeah.
guess is what I'm trying to get at. And so it's
Yeah.
So I
not.
wouldn't look to Foundation for it. I would look back to my original pathology.
Yeah, so they would need the tumor tissue, and then you stain, and again, it's basically you go back to microscope and you look under, and there's the circle, and they're measuring the percent of tumor cells that have that PD-L1.
Thank you.
Questions? Okay.
Thank you. In a clinical test, how often is a biopsy done? And what determines when you get a new biopsy if you've already taken a biopsy?
It's a really good question. So ideally, we always want a biopsy at diagnosis. So when we find something abnormal, whether that's a lung mass, whether that's a lesion in the liver, I prefer a site that's metastatic, because I think that gives us a little more information as well. But at diagnosis, I do think it's important at progression if you can as well. Part of that is balanced with what is the urgency of the need to start treatment. So say you have multiple liver lesions and you're worried that the liver is running into an issue of failing. Is it something where you need to get therapy started quickly to try to control the tumor and then look at a biopsy once we're feeling better and more safe to do so? That's where the blood-based testing comes in, that I think is really a helpful resource, where it isn't something where you have to go through a biopsy initially. We can at least look in the blood for circulating tumor DNA. Can we find a mutation or get a better idea of the profile? Each of those that's the hard part with every trial we look at, is we have new techniques to do that. So it's becoming more and more expansive in terms of what we're testing for. And so each trial may have looked at one specific kind of way to test it, and now we're finding a newer way to do it. And so I think that's really great, because we're getting more groundbreaking results, but it does make it confusing for us to know which one is technically going to be the best when we don't know that. So to answer your question, I think diagnosis is always important. I think it's important at progression as well. But part of that you have to balance with how are you feeling at the moment. And then certainly can we use, if we're worried about more of that urgency, maybe a blood-based testing at that time of progression. Do we find anything? And then if we need to look at a tissue biopsy at that point, do we at then?
Okay. How often do you have your patients get scanned?
So that depends in part. So part of it depends on the treatment. So if we're looking at a early stage 1 lung cancer that's been resected and cut out, so if it's a stage 1A or even an early stage 2, then a lot of times it's about every 6 months with a CAT scan. If we have something that we're more worried about, that there was lymph node involvement, oftentimes, again, we have to factor in treatments that we're using then, but we look a little bit earlier, about every 3 months. If we're looking in metastatic setting where we're treating and we're starting a new therapy, say we're doing that chemotherapy and immunotherapy combination, initially I like to get it about every 6 weeks to start. And we kind of gauge how is it responding, how is it working, and then we kind of, it's, I think, an approach with the comfort level is both of us in terms of how frequently we do it, but if we're doing well, do we space it out? Do we kind of limit? Because again, I think we have to balance financial toxicity too with what is also going to kind of benefit you. So if we're responding really well, can we go from 6 weeks to 12 weeks? Part of it's also making sure we check in on how you're feeling. Are you having any new symptoms, new pain somewhere? So how frequently I do it depends on what treatment has been received and then what stage and what risk.
I guess I'm going to piggyback off of that one also. We were discussing earlier at the table, like how often you get a PET scan, how often you get a CAT scan. How do you decide which one you do? Because I know I've spoken to people who are like, oh, I've had 5 or 6 PET scans, and I'm like, oh, I haven't. So I guess just wondering why certain people have a PET scan, other people have CAT scans, or MRI.
No, yeah, and the tricky part is some of it's not always black and white either. There's always certain preferences that go into it. You know, I always say every tumor type is different too. So you do have to balance with when you're talking to friends, family, or someone else, every tumor type is a little different. So if you have someone who has lymphoma, we tend to use PET scans a lot more often. And we use that as a way to kind of assess response. With lung cancer, oftentimes we use a PET scan at the initial diagnosis as a way to hopefully get a baseline. Now, I will make a note, PET scans do not cover the brain very well, so that's where if we have anything that's more advanced, so something that's getting into that stage 1B or 2, the standard would be to get a PET scan plus an MRI of the brain. So important to recognize that PET, while we say it goes head to toes or knees, doesn't actually really, not a great scan for the brain. But a PET scan is not necessarily always the best test, in my mind, to follow the cancer. So I tend to prefer initial PET scan at diagnosis. We get a good idea of the baseline, and then use a CAT scan, oftentimes with contrast, if we're able to from a kidney standpoint, because I think that contrast, it's a different contrast from the PET scan contrast. It gives us a little bit, in my mind, a better measurement that we can follow over time as well.
Okay, and my other question had to do about, is there something about a person's lungs, their lungs, that predisposes them, like a history of asthma, bronchitis, pneumonia? Does that have anything to do with perhaps developing? I mean, I know smoking and asbestos and all those things, but is there something specific about scars and past history of disease that predisposes someone?
Yeah, I think that's certainly very apt kind of statement or question, and that when we mention kind of even never smokers, so those who never smoke, we see like EGFR mutations you might hear about, or ALK is often seen in our patients who don't smoke, and we wonder, well, how did that happen? How did that light switch get flipped from off to on? And so we don't have an exact reason, but I agree. I do think it makes sense. Anything smoking is irritant to the lungs. It's causing inflammation. It's causing that body to have to respond to that. It brings in immune cells, and again, I think it makes that's where we see that flip switch. And so I think anything that leads to that chronic inflammation certainly puts us, and we know, at a higher risk for lung cancer. So I do think that there's a role there. How we quantify that role to then say lead to screening test is still an area that we're trying to work on and figure out. So that's somewhere where we're certainly not there. We hope to be there. You know, at Levine, we do have a what we call lung bus. It actually goes to a lot of areas that maybe don't have access to healthcare and are able to do screening, low-dose CAT scans. And we do have a study there where we're actually looking at more of a young adult population as well, and enrolling to look earlier, and does screening earlier help? But again, that's still patients who smoke. So I think in the case of what other inflammatory states are there, that we can actually increase our screening tools, because we know the earlier you catch lung cancer, the better. And that's where we need to figure it out.
Okay, I'm coming. We're going to have you back this afternoon on the panel too, so.
I have one more question. I was a stage 1A2 resected, and I'm coming up on having my first CT scan. And I have conflicting opinions. I've had one, it's 5 months right now, and it'll be my in a month, that'll be my 6-month checkup. I've had one doctor tell me that my CT scan needs to be with contrast, and I have another that has ordered it without contrast, and I just don't know which way to go.
There's no right or wrong. I think both scans are certainly appropriate. You know, if you kind of pull up, it's never really been studied to say with contrast versus without contrast. I think with contrast helps us not so much for the lung fields. It does help to look at a little bit of the lymph nodes more. But if you're kind of going off, if you pull up the guidelines and you say, I'm going to go kind of black and white what it says, it's kind of listed with or without. So there is not technically a standard in that case, and so it becomes a little bit of a personal preference. If you have kidney disease, your kidneys aren't functioning as well, contrast does run the risk of possible injury to it. That's a little bit of an area that comes up for debate in the future, but that might be one reason to limit the amount of contrast, is you don't want to possibly injure the kidneys, so that is one limiting factor in there. I've had some patients that have reactions to contrast, whether it's an allergy or nausea. So in that case, if it's something that we can't do, then do without. So part of it is the balance, I think in terms of there, but there's not technically a right or a wrong, I would say.
Okay, cool. Well, you're going to be coming back this afternoon for our panel, and thank you so much. That was a fantastic presentation.